patient blood management of the year. And it is an exciting session for me because we're doing something a little bit different and a little bit new. We've got a very special speaker with us today who has spoken on this and many other topics related to iron deficiency on this platform on a number of previous occasions. But this one is really exciting because the role of iron in athletes and in sports is getting more and more center stage. Recently, the European Hematology Association has brought out some guidelines with regards subgroups of the population that require screening for iron deficiency, and amongst them was athletes. And I see Claire smiling knowingly, so I'm sure she's going to refer to that as well. But it is really wonderful for me to have Dr. Claire Barrett here with us this afternoon. She recently also spoke at one of the Stellenbosch Sports Institutes on the same topic. And Claire is a very good friend and colleague from many years now already, from Bloemfontein's days. I guess we're almost going on for close to 20 years. And Claire is head of research and development at the University of Free State Faculty of Health Sciences. She's also a specialist physician. She's worked in clinical hematology for many years. And Claire, great to have you. Look forward to your talk. I see or I note here on our WhatsApp group that there's some people that's struggling to get in, so I'm quickly going to see if I can help them. But with that, welcome and over to you.
Thank you very much, Vernon, and thank you to everybody for inviting me. And even if this is more going to be, as Vernon advertised it, a bra-face presentation, that's good. And I think we've got something to talk about over the holiday season that's not work-related. It might even fool people into believing that we might even be balanced individuals. So let's go. So just to, as in terms of my disclosures, that I've received honoraria from various iron-related companies for educational activities that I have presented for them. And these opinions are my own and obviously based on as much data as I can get my hands on. And they're not that of the University of the Free State or anybody that has sponsored me in the past. So we're going to have a look at the following in this presentation. We're going to look at the prevalence of iron deficiency in athletes. Then also the relevance and why is it a big deal, if at all. We're going to look at a bit of a tricky subject, and that is the definitions of iron deficiency in athletes. And we're going to challenge what the currently published literature is in that regard, because I think it might be a bit dated. Then we're going to look at treatment. And something that is more and more important to me is the monitoring of treatment. And hopefully I'm going to convince you that it's not enough to just, do a screening and then give this patient a couple of iron tablets and not follow them up. But we're not going to be looking at the therapeutic role, if any, of iron therapy in iron-replete athletes. So we're not going to talk about sports anemia either. Sports anemia is something that is, has been born, many, many, many years ago, and it was basically normalizing anemia, specifically in endurance athletes. And, they proposed that this was due to hemodilution. These athletes, specifically runners, are running long ways, they're drinking a lot and redistributing their plasma volumes. And like I say, almost normalizing anemia in these patients. And it's controversial and it's not really very data-driven. So we're not going to be speaking about that. I'm not very good at physiology, and Vernon, I'm sure, has through many of his lectures told you all about how fancy the iron regulation is in the body, but I sort of work on you eat the iron, a miracle happens and it lands up in your bone marrow. I've put in 1 or 2 extra steps here to make it easy for you. So you eat your iron and then it gets absorbed, goes into the plasma, and there either it goes to the bone marrow where it's used to make erythrocytes, macrophages then recycle the old erythrocytes and it goes back into the plasma, or else then stored in in your bodily stores, specifically the spleen and liver more. What happens if I've got inflammation is that hepcidin is released, and then I sequester my iron. So either I'm storing it in my bone marrow, it's not being released from my macrophages, and certainly I'm not able to absorb it nicely either, because hepcidin controls all of that. And this is really a case of starvation in the midst of plenty. So where you've got ample iron stores, but it's not being released into anything particularly useful. And then obviously anemia comes, and then this causes anemia of what we used to be called anemia of chronic disease, and now known as anemia of inflammation. So I think to this audience, you've probably all heard the important lab tests, but just to sort of just distill it, because I find that sometimes people still do get confused with the laboratory tests. So if I didn't have enough money and I wanted to do one test to make sure that this patient has got iron deficiency, or I wanted to exclude iron deficiency, my one test would be a ferritin, because this gives me a good idea of my iron stores. There are, the other tests are extremely important. So where your serum iron looks at your free iron, transferrin looks at the protein that binds iron and moves the iron around in the circulation. And between serum iron and transferrin, a formula is done in the lab, and then they produce this percentage, which is called the transferrin saturation, or TSATs as it's commonly known. And this then shows how much iron is available in the plasma. So I often think about it like this: ferritin is your money in the bank, and transferrin saturation is your money in your pocket. So if I might have lots of money in the bank, so my ferritin might be extremely high, but my transferrin saturation, my money in my pocket, is little, and that is what would happen in anemia of inflammation. So I've got all this money in the bank, or all my iron is stored in my bank, but I can't access it. So similar to being a trust fund baby, I can't access this money until I'm 25 or 30 or 40 or whatever the trust fund says. But the converse is also true. It might be that my transferrin saturation might look pretty good, but my ferritin might be extremely low. So does it help to have lots of money in my pockets, and I can go to the tuck shop every day, but I've got no money in the bank? And this is what we see in iron deficiency, where the ferritin stores are low, and why I'd like to say that maybe the transferrin saturation doesn't really matter if the ferritin is very low. So, and there are some things that we'll talk about in this lecture of what can affect your transferrin saturation. But just as an example now, if you took an iron supplement that morning that your iron studies were done, your serum iron might actually be increased because you took that iron supplement. So because transferrin saturation is based on a formula, if you increase your numerator, your percentage is going to look better than what it really is. So that's why it's not really a particularly useful test if you did take an iron supplement, for instance, in the morning, and other things can affect that. I'm not rubbishing the role of transferrin saturation. It's got a very important role, but I would not use it to exclude iron deficiency. So I want to ask your professional opinions, and if you're comfortable to do so, you can scan this QR code, which I'm going to leave on there. And on that QR code, you are going to see a number of symptoms. So these are really random symptoms. I've alphabetized them, and if you would like to, please take out your phone and scan the QR code. And what I want you to do is I'd like you to click on every symptom that you believe is related to iron deficiency. So, and more than one is true. So you can click on the ones that you think are relevant, and click past the ones that you think are not relevant. Iron deficiency is the most common nutritional deficiency in the world. And in fact, iron deficiency plays an extremely important role in quality of life in many aspects of, in different population groups. But today we're going to speak about specifically how it affects sports people. Let me just finish on my little questions. So, and we're going to touch on them a little bit later, but if you saw 25 symptoms there, and if you did not click on all of those 25 symptoms, you actually missed the ones that you didn't click. So all of those symptoms that are on that QR code are actually symptoms of iron deficiency. So the purpose of this was to try and make it real for you, and that you really do realize how important iron deficiency is and how it can masquerade as so many things outside of anemia. So the prevalence of iron deficiency in athletes, and we're going to start sort of young and perhaps novice athletes and work our way into the more professional athletes. But the prevalence of iron deficiency in adolescent athletes is extremely high. So depending on which data you read, and I think what's very, very, very important is that sort of deciphering this data is like going into the pyramids and deciphering hieroglyphics, because you just notice even in published articles how many people do not use the same definitions of anemia. They don't use the same definitions of iron deficiency. So it does become quite difficult. And I think it explains a lot why you might see these huge big variations in the prevalence of iron deficiency. So when you read anything about iron deficiency, the first thing I do is, how on earth did they decide that this was or was not iron deficiency? And this then says, well, maybe why this prevalence is very low in some groups and very high in other groups, maybe where they use the more sensitive test. But be that as it may, in adolescent athletes, there's quite a spread, but with a very high, percentage noticed in some novice, high school athletes. Why do these kids often get missed? Is that we think that they're young and healthy. They're kids. They've got no chronic conditions. They are just, young, healthy kids. But we forget that, especially for the female teenage athletes, that they've often just started their menses. Yes, they don't have kids yet, but they are still developing. And we know that that's one of the times that your iron need is actually increased, is when you are going through periods of physical development. And for those of you who have got teenagers, you'll realize that physical development really is massive and marked and happens before your very eyes. So yes, these kids have got an increased need, and often we forget that they might be iron deficient as well. Adolescent athletes are very often very body conscious. They feel that everybody's watching them, and obviously they keep their body mass index as low as possible. It helps them with their performance, they believe, but it also seems to correlate with the risk for iron deficiency. So don't forget about it in these young kids. So then in collegiate athletes or university athletes, there was quite an interesting study where they looked at the ferritin at the beginning of a season in both freshmen, so first-year university students, and then more established students or upper-class long-distance athletes at that university. And they found that even if the ferritin was normal right in the beginning of the season, as the season progressed, they kept an eye on their ferritin, and they noticed that these athletes' ferritins actually dropped throughout the season. So it's sort of touching on what Vernon was speaking about, screening of athletes. But I think this is a reminder that, how often should we screen and when should we think about screening athletes? Interestingly, in this study, well, it was a thesis, ferritin correlated with the athletes feeling ill or injured. They didn't sleep as well, and they perceived themselves as more tired than the iron replete athletes. So this is important in this group, and and I think this theme of injury is very important, and there's not good data yet, and I hope in time it will happen. But I often tell the students or anybody who will listen to me that, why does your sclera become blue with iron deficiency? And your sclera is actually just collagen, isn't it? So we need iron to make good, healthy collagen. And we also, where else do we find collagen? We find it in our tendons and in our ligaments. So if we are iron deplete and it can make our sclera go blue, what other collagen ligaments and tendons are also becoming not blue but weak. And this, I think, makes perfect sense to me that iron deficiency would be related to frequent injuries. So this is, I couldn't find something that only spoke about iron deficiency in this group, but iron deficiency anemia in triathletes and runners. We saw that the prevalence of iron deficiency in this group was also all the way up to 60%. Interestingly, the prevalence was higher of anemia in males than in female athletes. So I thought that this was a reminder that, you know, often we, and even when I started talking, you know, I said that young girls are menstruating, and this is obviously a risk for iron deficiency. But it seems that when the athletes and the male athletes start really training hard, that even though they're obviously not menstruating, that they actually have a higher risk of developing iron deficiency anemia. And we need to remember that, and not only be only focused on female athletes, but remember that this chronic inflammation that happens with running, and you know that stress that happens with severe exercise actually also increases your hepcidin expression, therefore reducing iron absorption and leading to iron deficiency and iron deficiency anemia. So the prevalence of iron deficiency in marathon and half marathon runners. So this now sort of swapped it around again, saying that the prevalence of iron deficiency for males was 15%, females was 47%. And here they found some specific risk factors. Was younger athletes. So again, just a reminder that we need to think about it from young. If the person has had a previous history of anemia, if they've got heavy menstrual bleeding, and I don't know if what he is on the talk, he said he might be, but you know, this is one of his passions, is how we don't ask our female patients about a history of heavy menstrual bleeding. And we must remember that these people with heavy menstrual bleeding are not going to volunteer that information themselves, because many of them consider their heavy menstrual bleeding as normal, because their mom bled like that and their sisters bleed like that, and they consider that normal bleeding, and they think that other people who might have normal periods are actually just the lucky ones, whereas actually they are the unlucky ones. Patients that were using, as they said in this article, blood thinner use, more than 15 hours of exercise per week. So that is quite, you know, that's about 2 hours a day and resting on a Sunday. But if you think about it, my daughter was a swimmer. She swam for 3 hours 3 times a week, and for the rest 2 hours a week. So it is quite possible to make up those hours. Restrictive dietary habits, and then also people that complained of lightheadedness, which I think in this case was probably related to anemia, although not measured, if I remember correctly. So why do athletes get this terrible thing called iron deficiency? So we know that athletes are often picky eaters, and you know, between them and vegans, I'm not sure who the worst is to have at a party, because, you know, they analyze everything that you put in front of them. And I say that because I know both groups, and I'm teasing them, but they are very conscious about what they eat. Interestingly, strenuous exercise is related to gastrointestinal blood loss. And I always, before I started reading to prepare for this, I always thought, well, perhaps, you know, that it was completely just related to the hepcidin release. But gastrointestinal blood loss, and it's obviously occult, small little bleeds gastrointestinally. And there was one study that even looked at, they did isotope labeled red cells, and found that in athletes there is actually, that demonstrated gastrointestinal blood loss in endurance athletes. So don't forget about that. Hemolysis, and that would be like the March hemolysis, patients who, or athletes that run very far, marathon runners, you know, that constant compression on their feet from that causes a degree of hemolysis. Hematuria is less. Sweat loss, definitely sweat contains iron. Intense exercise or activity and like I said earlier, that causes a release of hepcidin, and therefore, even though you might be eating enough iron, you might not be absorbing it properly. And then also that they are maybe not taking enough iron, and that they're not taking an iron supplement as well. So how does iron deficiency affect the athlete? So iron deficient athletes, compared to iron replete athletes, complain of weakness. They don't have the same power that they used to have or that they would have liked to have had. They are tired or fatigued. They express that their performance is not as good as they believe it should be. Their heart rate increases and they become more short of breath. They are headachy and become irritable, dizzy, frequent injuries, recurring illnesses, and some studies even report a loss of interest in the sport that they love so much, which I think is the biggest loss of all, is if somebody is so passionate about their sport and they now start questioning why they do it, and I'm not getting the performance, I'm putting in hours and hours and hours, but I'm not getting what I wanted to get. And my friends that are training maybe an hour or two less than me are getting better results. And I mean, all of these things together, I know would make me lose heart in this sport and make me think, well, perhaps I'm not actually that interested in it, and maybe I should take up something else. So these symptoms are extremely important, and a sport is not work. A sport is something that people do for fun, and they need this, and it's part of their life balance. And these symptoms are symptoms that I would take extremely seriously in somebody who is passionate about their sport. So why is iron important at all for athletes? And I think that we know that if you're iron deficient, you actually can't perform as well as you would like to. And that's because, and that affects not only your aerobic performance, in other words, what your mitochondria are doing and how this energy is being produced, but it also affects athletic endurance. And studies have shown that iron is crucial, not only for that time when I have to perform, but also in your conditioning and getting ready for your race, importantly for your race recovery, and then also for your endurance during the race. So all three phases of exercise are dependent on iron. So we're going to talk a little bit about the pleiotropic functions of iron and go step by step as to why this becomes a big deal. So the first is, and we don't need to convince anybody in the room, I hope, that iron is important for red blood cells. So I don't know what I always used to think, but I don't think it anymore. But I've sort of always imagined a red blood cell had, a couple of little hemoglobin molecules in them, and that made them nice and red. But actually, a red cell contains 270 million hemoglobin molecules. Each hemoglobin molecule contains 4 iron molecules. So one red cell contains a lot of iron. That's in girl maths. But what I want to illustrate by this very impressive lot of iron in every single red cell, you can lose a lot of iron. And you before your red cell is going to change its color, it's going to change its shape. So I'm talking about hyperchromia and microcytosis. So you're going to have to lose a couple of million hemoglobin molecules before your red cells are going to change the way they look under the microscope. And I use this as a reminder to say, don't wait until a patient is anemic before you think about iron deficiency. Red cells are probably going to look pretty much the same despite iron deficiency. So think about it early and investigate. And we need to sort of step away from this algorithmic approach to investigating iron deficiency, saying, well, my MCV is less than 80. Now let's do the iron studies. And we need to start thinking about iron deficiency long before the MCV becomes low. Then iron is very important in the mitochondria, and iron plays an extremely important role in ATP, synthesis from ADP. And without iron, that process cannot happen. But it's also important for thermogenesis and physical growth. So we need iron to make our cellular respiration work well. So without iron, or an iron deplete state, enzymatic activity in the Krebs cycle is decreased. So that means that that less ATP, less NADH, and less oxygen is being able to be consumed. Also, my oxidative phosphorylation, glycolysis decrease, and my lactate increases. Now, athletes hate lactate, and they say that it makes their muscles sore, but perhaps these are things that we need to really think about in our athletes, where, energy, and specifically bursts of energy, are extremely, extremely important. I think it's important that this reference that I've used here is from an oncology journal. So it's not applied in the sports medicine, but this was an argument that was made of why iron depletion is so important in cancer patients as well, for similar reasons, but I'm just applying it in sports medicine now. So iron is also very important in muscle mass. So we know that both cardiac and respiratory muscles are affected by iron deficiency, and even in non-anemic iron deficiency, so long before this patient is anemic, both cardiac and respiratory muscles become weaker. Iron deficiency is related to low muscle mass independent of your hemoglobin. So basically saying the same thing again, but you're going to see these effects before the patient is anemic. So iron deficiency impairs myoblast proliferation and aerobic glycolytic capacity, and also induces markers of myocyte atrophy and apoptosis. And this is fascinating. So not only do I need it for my muscles to work, but if I'm iron deficient, I'm going to undergo, so this is in the myocytes, that those myocytes themselves are going to atrophy or apoptose. So iron deficiency contributes to a loss of muscle mass, which obviously for a sportsman is drastic. But think about it in the context of, in any patient, in patients that you want to get up after surgery, in older patients where that muscle mass is very important to try and prevent that sarcopenia that's related to general aging. So I think that we must think and really acknowledge the importance of iron deficiency in muscle mass. Iron plays an extremely important role in loads of enzymatic functions, and that has been discussed, at quite a number of these sessions. So we're not going to go into it in detail, but just to remind you that it's not all about hemoglobin and myoglobin even. It's about cytochromes. It's also about I put the little picture of the brain with the little bubbles coming out of it there to remind me how important iron is in neurotransmitter substances, especially dopamine, serotonin. And if you look at, and noradrenaline is the other one, is that if you look in studies related to depression, it's very important how iron plays a role in the serotonin reuptake and all the reuptake and the recirculations of these neurotransmitter substances. And yes, we're not talking about depression, but this is important for big match temperament, and it plays a huge role in just the psyche and keeping enthusiastic about your sport as well. So yeah, so iron plays a role there as well. And also in loads of other enzymes. So 6.5% of all enzymes in our body are dependent on iron. How does iron relate to our VO2 max? So VO2 max, or our maximum oxygen consumption is a formula that is sort of churned out by the people, but it's a maximum amount of oxygen that an individual can utilize during intense or maximal exercise. And it's one of the best indicators of cardiovascular fitness as well as aerobic endurance. So when they compared people with normal iron stores, they found that participants in this study who had iron deficiency were unable to reach the same peak VO2 max. So this meant that that despite the exercise, despite everything else being similar between these athletes, iron depleted athletes were not able to perform and reach the same endurance and oxygen consumption as other athletes. What they noticed in this study was that iron deficiency was more common in females and especially young athletes. So I think we need to watch this space. This article was published this year, and perhaps we're going to see more coming out of this, showing how iron deficiency affects, our aerobic exercise as well. Then there is the question of the female athlete and the triad of being the female athlete, where they're often balancing their reproductive health. And we know that female athletes often have amenorrhea. Some of them actually have menorrhagia, but their whole the sex hormone synthesis and balance becomes very much affected in just by being an athlete. Forget about being iron deficient. And then bone health is a big deal, especially in female athletes, but actually in endurance athletes as well. And then low energy, that is often related to diet and these very low fat diets, and again, just being a picky eater and not having a good balanced diet. So this is something that we see in female athletes. But what happens when you sort of overlay that with iron deficiency? And this becomes quite a big deal, because now suddenly I've got this compromised reproductive function already, with impaired fertility, impaired GH secretion, hyperprolactinemia. Bone health is already compromised by this intense exercise. But we've also got this thing, and I highlighted it here to say this hypoxia-induced bone resorption. So by being iron deficient, or even worse, iron deficiency anemia, can actually result in an acceleration of your bone resorption. And obviously that would also affect your energy status, like we've already shown. So the female athlete triad poorly tolerates iron deficiency. So this is back to that little survey that we did, where these were the 25 symptoms that I put up for you, and I hope you ticked them all. But this article actually really is quite interesting, and how they did it and looked at iron deficiency and the symptoms related to iron deficiency. So we can see that this is just in the general population of women. Men did not participate in the study, but fatigue was very much high up on the list. Exhaustion, brain fog, muscle weakness. It looks like more than 70% of the females that participated in the study complained of muscle weakness associated with their iron deficiency, shortness of breath, and then feeling cold, dizzy, anxious, palpitations, irritability, hair loss, and so it goes on with all of these symptoms that I think we often remember one or two of them. And, if the patient, we glance at their conjunctiva and we say they're not pale, so therefore this is not iron deficiency. But if patients are complaining of any of these symptoms, we need to start thinking about iron deficiency. So what was interesting, if you go and look at the actual data from this study, and it was published earlier this year, that being a mother, was more likely, those patients were more likely to be iron deficient if they were following anything other than what they considered a standard diet. Those patients were more likely to be iron deficient, and very significantly, any patients who had heavy menstrual bleeding as well were more likely to be iron deficient in the study. So that was interesting to me. Then exercise-induced illness and inflammation is a thing for athletes. So, and this is related to sleep disruption and often the environmental changes from, moving, from site to site where athletes participate, often all over the world even, but also the physiological, metabolic, and psychological stress of being a high-performing or elite athlete. And this results in immune dysfunction, inflammation, oxidative stress, and muscle damage. But now, on top of that, we then bring in, and what I showed you, I've sort of had a little picture of a white blood cell, but a lot of the processes in the white blood cells are also or are also dependent on iron to function optimally. So, you know, again, put a vellum of iron deficiency over this syndrome that we already know exists, exercise-induced illness and inflammation, but on top of that, add iron deficiency. And what are we going to, you know, we're going to have an even more compromised athlete. And that's often why I believe that many athletes, you'd think that they would be the healthiest. You know, they're always exercising, they're always watching everything that they eat, they're taking tons of supplements and nutrients, you know, from all sorts of bottles, but they're always sick, and it doesn't make sense. But perhaps we don't acknowledge the immune dysregulation that occurs with intense exercise, and I believe missed iron deficiency as well. So this was a study and it was done years ago, but looking at supplements that were taken by elite athletes. And interestingly, you know, loads of them take at least the RDA of phosphate, vitamin B1 and B2. But interestingly, most of these athletes took less than even just the recommended daily allowance of iron and calcium. And both, I mean, we all know that the recommended daily allowance is not treatment doses. It's just, you know, like a really pure minimum amount. And I was surprised by this, because I would have thought that, considering the implications of bone health with endurance athletes, and then obviously iron, I would have thought that those would have been the ones that would have performed better. But it seems like people are very much still focused on the B vitamins in athletes, and forgetting about the minerals that are necessary for them. So what is low energy availability? So this is often something that is seen in female athletes, specifically, and I put the ballet dancers or the gymnasts there to, you know, it's typically occurs in athletes where their body and their weight is very, very, very important. So here they have a mismatch between what they're eating and the energy that they're expending. But what happens with this low carbohydrate and often high fat diet, it actually increases hepcidin and then worsens your iron absorption. So as much as they've got this mismatch between their energy intake and expenditure, they also then are starving their cells and their mitochondria and their muscles of enough iron to be able to perform properly. So this is a group of athletes that you need to really watch carefully. So I put here IDK, so I don't know. It seems that athletes are pretty clueless regarding the symptoms of iron deficiency. And this was a study that was done just, you know, looking at athletes and which are the symptoms, similar to like what I did with you guys, what are the symptoms of iron deficiency that you recognize? And athletes don't recognize that a lot of the symptoms that they've got are in fact symptoms of iron deficiency. And I think that there's a healthcare role there also, that we need to start educating athletes about the symptoms of iron deficiency. And then I sort of put this as a sobering sort of aside, is that bad things happen to good athletes. So not all iron deficiency in athletes is related to exercise and inflammation. I've given you a really compelling argument about all these things that happen and why hepcidin is increased, but please remember that bad things can still happen to athletes, and we still need to take a proper family history, take a proper personal medical history, and we need to investigate athletes as well as we would investigate any other patient. Because it's not to say that, oh, you know, I went to this lecture by Claire on a Wednesday afternoon, and that's why you're iron deficient. You know, it's because you're exercising too hard. They may still have other good reasons or bad reasons to have iron deficiency, and they need to be investigated. So we're going to look at the definitions, and these are really tricky, and I'll be interested, hopefully Vernon's going to jump in with his study as well, of how we differentiate and define iron deficiency in basically, I think, in a daily changing environment. So I'm very conservative, so you're going to have to accept that from me. and I also like to sort of stick to the guidelines, and perhaps I'm sort of that intermediate adopter. But we'll have Vernon here for balance. So the definitions, I like to think of iron deficiency as a sum of non-anemic iron deficiency and iron deficiency anemia, because I think we've still got a lot of a huge, big educational role to tell people and advocate for non-anemic iron deficiency. Because when you talk about iron deficiency, even if you Google iron deficiency, your first, I don't know how many hits will be iron deficiency anemia. And you've almost got to say iron deficiency, not anemia, to filter out the non-anemic population. So we need to think of iron deficiency as still as very much missed, I think. And so how do we define it becomes important. So iron deficiency, the way I see it, is somebody who's got a ferritin of less than 50. And then that could be either I've got non-anemic iron deficiency, which means that I've got a ferritin of less than 50 with a normal HB, or else I've got iron deficiency anemia and I've got ferritin of less than 50 with a low HB. And that's, you know, pretty much as simple as we can make it. So this is something that it's archaic reference, and I'd like to challenge it, but I'm just going to, this is what I can find as the guidelines for staging of iron deficiency in athletes. And here they propose that a ferritin of less than 35 with a normal-ish, it's actually not normal, it's actually already anemia, you know, and this is why I challenge this guideline, that they say, oh, but this is just depleted iron stores. Reduce erythropoiesis, my HB is at least more than 11.5, but let's be honest, I mean, even for a woman that's low, and this is then diminished erythropoiesis, and then iron deficiency anemia. They say that that's a ferritin of less than 12 with an HB of less than 11.5 and TSATs of, I'm sorry for the spelling error, of less than 16%. So I don't like this very much, and I would rather stick at least to a ferritin of less than 50 as my watershed for saying iron deficiency. And later on, we'll just talk about other people's opinions about that as well. But let's say we want to test, because now we're at the BRIFLACE and people are saying, but you know, what should I do? You know, shouldn't I be testing? What do I need to do to now make sure that my kid athlete doesn't have iron deficiency? So I think my very minimum test would be a ferritin, a hemoglobin as well, a transferrin saturation, and perhaps a CRP as well. If I want to follow an algorithmic approach where I say, well, if my CRP is high or more than 5, I actually need to make a higher ferritin cutoff. But for the athletes, it's important that they are hydrated properly before taking their iron testing. It should preferably be at the beginning of the season, before they've got too much inflammation. You know, generally at the beginning of the season, the exercise intensity is not that high yet, and they're still sort of conditioning and getting ready. You should not have done like a marathon the previous day. So you need to do low or moderate activity in the previous 24 hours. The person that has done a big race or like really trained really hard the previous day will have more inflammation. And we know that ferritin is an acute phase reactant, and actually that could make my ferritin falsely raised, and I'd miss that opportunity to diagnose iron deficiency in that patient. Also, you know, it's so tempting when you catch an athlete, you know, when are they going to come to the doctor? And generally it's because they're sick, isn't it? So they're going to come and they're going to see you, and they're going to have a flu, or I don't know, maybe a urinary tract infection. So they'll be sick, and you say, by the way, you know, let's just quickly do your iron studies. But I think that that's not a great time to test that patient, because yes, if the ferritin is low, for sure, that patient has got iron deficiency. But we might be, again, missing a lot of patients who actually do have iron deficiency, but because they're sick, their ferritin might be falsely raised, and we're going to miss that opportunity to diagnosing with iron deficiency. So if that is the time that you catch your athlete when they come to see you for their acute illness, give them the form, but tell them, you know, to wait until they are better before testing the blood, and don't do it sort of right there in the rooms, but refer them to the lab and let them get better for a week or two and then test them. The patient should preferably be fasting. They should not have taken supplements in the previous day, specifically, obviously, iron supplements. And also, if at all possible, do the testing in the morning. So these are just the little tricks to get a more accurate result, so that you've actually got something that's meaningful. Because these tests are not for free. They're not super expensive, but nobody likes wasting money, and nobody will like it if you phone them and say, oh, you know, these tests were sort of indeterminate. Let's repeat them again when you're feeling a little bit better. Maybe the iron will be lower then. And I can guarantee you they're not going to go back and retest. So this was the article that Vernon was referring to in the beginning of the lecture, is that so this is quite an impressive position statement, and it's an open access article, and I really, really recommend that you read it. So they made a list of people who should be screened for iron deficiency. Important, not iron deficiency anemia, but for iron deficiency. So they say that children and adolescents must be screened. Screened, not wait until they've got symptoms, screened. Athletes are second on the list. We must be screening our athletes. And then I'm going to go through this list because I think it's important. We need to screen our vegetarians, socioeconomically disadvantaged people, which is a huge proportion of our population, blood donors, pregnant women, menstruating persons. I mean, let's, you know, that's a huge chunk of the population. But, you know, so healthy menstruating people, we need to start screening them. Older adults, especially those with comorbidities, people who've got bleeding disorders, people who are on medications like anticoagulants, antiplatelet drugs, PPIs, history of gastrointestinal surgery, or those with chronic infections. And in our context, HIV is probably the most important one. But the point is that this is a huge responsibility to start screening patients, but don't forget about your so-called healthy athletes. So this is back to Peeling's studies, or not his study, his guideline. And I quite liked it because he makes an, assuming it's a he, makes an argument about actually that once annually is not enough to screen athletes for iron deficiency. So it says that at least annually, you should do it if the patient has got no history of previous iron deficiency, not menorrhagic, not fatigued after extended rest, and, you know, got a couple of other things there. But for your female athlete, they recommended biannual iron screening. And then also, especially those who have a previous history of heavy menstrual bleeding or irregular menses, previous history of iron deficiency, twice a year. And then also those who intend to undertake high training loads in endurance and team sports. So minimal reports of prolonged fatigue, you know, only twice a year. No dietary restrictions, none of this low energy, I can't remember what it stands for now. Sorry. And then intention to undertake hypoxic training in the next 12 months. But the minute the patient has got a recent history of iron deficiency in the last 2 years, or any history of heavy menstrual bleeding or irregular menses, they need to have, well, this is his guideline, is to have quarterly iron studies, high training loads in endurance and team sports, prolonged fatigue or lethargy after rest. And he goes on, and we don't need to read through it all, but basically making a very strong argument that in athletes, testing and screening for iron deficiency is not something to be taken lightly. At least it should be done annually in elite athletes, biannually or quarterly, depending on which group these athletes come from. So what's it going to cost your patient? I think it is important that we discuss this. So a full blood count is going to cost around $275, a ferritin about $270, and transferrin saturation about 389 Rand. And this is also one of the reasons why I say perhaps if you wanted to start with a ferritin, because you don't need a transferrin saturation to make a diagnosis of iron deficiency. It does become important if you want to tease out the more tricky ones. And then, so I went on to Dischem's website, and I mean, so yes, GU, so that they take like 2 or 3 of these per like events. raced food or bars, they cost a fortune, 78 Rand. And then this whey, it costs, I mean, this you're going to go through in more, more than one a month, 735 Rand. So I think that these pale in comparison and are actually really, at least here, there's evidence based to say, well, if I could fix my ferritin, actually your performance will get better. Whereas these, is there any evidence to say that this is going to work? But yet they flock and buy these. And me as a mom of a kid who swam, I can tell you I've spent an absolute fortune on these things. Then there's home testing available as well. So FerriCheck is now marketed again in South Africa. It costs about 190 Rand and people can buy these. The problem with the FerriCheck is that the ferritin cutoff for the test is 20. So you're going to, only if you really iron deplete are you going to pick it up. But there are, what happens between that 20 and 50, and those patients are going to believe that it's okay. And is it such a saving? They're going to save $100. I'd probably rather go to the lab and do it properly and also have something that is, instead of this is a binary, either it's like a pregnancy test. You're pregnant or you're not pregnant, but you don't know, what your starting off ferritin was. Whereas a blood test will tell you it is 23. And then I can, treat for a month and see did it go up at all. But I think it is important that if patients do want to know about it, these tests are available and can be used. So we need to address iron deficiency properly with diets, oral iron or parenteral iron, and there's a role for all of these. So we know that meat is probably the best way to eat iron. It's easy to absorb and it's very tasty. But perhaps there's, if we're going to give oral iron, I think it's also important that we advise our patients how to take it. So generally it's recommended to take it in the morning, but there was a study that came out, I think, actually I can't remember, but not so long ago, looking in ballet dancers, whether they took the iron in the morning or in the evening, and it actually made no difference in terms of the response to the iron therapy. But I mean, most guidelines say in the morning, but I think the jury's still out there, but yeah, should be taken after exercise. And this was quite interesting to me because you'd expect that after exercise that your hepcidin would be increased and perhaps you wouldn't absorb your iron so well. But there was quite a sweet study that they did, and they looked immediately after exercise. Seems to be a really good time to take your iron, and that your iron absorption is actually quite good then. But a little bit later, then your hepcidin goes up and then you don't absorb it. So, if you go for your morning run, come back and have your iron. And then if you're going to take iron sulfate, alternate daily dosing is what is required or recommended, and at least 30 to 60 milligrams. But I mean, we actually know it's 60 to 200 if you are iron depleted, and that's of elemental iron. So there are, there's this talk about daily or alternate daily, and there was a big study done on ferrous, well, not whether it was a big study or not, no, there was a study done on ferrous sulfate saying that the absorption was actually better if taken alternate days. But it's important to remember that study was done on ferrous sulfate. So I could find another study that looked at ferrous bisiglinate. And here they showed that whether you took it daily or alternate days, the ferritin both improved nicely. But daily actually showed a better improvement in your ferritin, but the side effects were worse. Compliance was similar. So I'd say that, if you want your ferritin to get really good and the patients can tolerate it, take your ferrous bisiglinate daily. But if there are complications like nausea and constipation, rather take it alternate days. But yeah, you can read that study. It's a nice read, and it specifically looks in athletes. I think the reminder here is also to listen to your patient and not just do what you think is right. So the type of oral iron, I think, is also important, and we would preferably want to take a small iron molecule that absorbs well, preferably paracellular, and also that it absorbs independent of hepcidin. And there are molecules that do this. It is also important to remember that there are other things that patients might be taking that iron can affect. So integrase inhibitors used to treat HIV, bisphosphonates, and this is important because we know that athletes are actually at increased risk of getting osteoporosis. Taking iron at the same time as your bisphosphonates, if you're taking them orally, reduces the absorption of bisphosphonates. And actually, almost all the drugs in the thyroid hormone group, the absorption of that is decreased if you take iron concurrently. So the suggestion is to at least wait 2 hours and to separate those drugs by 2 hours. Otherwise, you lose you take the iron, but you lose the actual other drug that you were taking. So vitamin C, there is data that suggests that vitamin C is historically what is a good idea to take with iron, and it improves absorption. But there is also data coming out now that says that vitamin D suppresses hepcidin. So if your patient, and specifically your athlete, is vitamin D deficient, and often we don't think about it because we think these guys are outside all the time, and surely they'd have normal vitamin D levels. But if you could get and this, I don't know why I didn't put the reference here, but it's recommended that you keep a vitamin D of about 40 to sort of reduce that hepcidin and actually improve the absorption of iron. And then obviously also treat the other deficiencies like B12. So, the books say that you should aim for a ferritin of at least 50. I'd probably push it up to 100, and I'm going to put Vernon in the spot and he must say something there. And I mean, and there are in heart failure, especially where they suggest that if the patient has got inflammation, as evidenced by a CRP of more than 5, which is really little, but this is inflammation with a low transferrin saturation. And this is where your transferrin saturation becomes important, is in these higher ferritins of what to do there. But I mean, there are people that would argue that you could aim as high as 300 if the CRP is high and the transferrin saturation is still low. I think we're going to have to watch and see what the data advises here. This is a very special group, and athletes, but hopefully data will come out to guide us. So thank you very much for listening to me, and I hope that maybe you've got something to chat about around your bra over Christmas.
Claire, excellent, wonderful. I was really, really excited to see quite a few new things that I've not come across before. And I'm very interested in that reference about vitamin D in particular. So thank you for sharing so many interesting and useful things. I think the link was sorted out because we suddenly had great attendance within a few minutes. So welcome to all of you who came a little bit after the initial welcome. I'd like to open the chat or ask for anybody in the chat if you want to ask any questions, please feel free to do so. I've already seen some comments from people in the audience, some saying that they're seeing, okay, there's a private message, but I can just say generally somebody said they see a lot of athletes with low iron and think that we're probably still screening too few of them. And some of them actually remain at low levels despite getting certain supplements. And I think it's one of the things that does concern me a little bit is where sometimes people are only using supplementary doses in people who have really significant iron deficiency. And I think we can sometimes be underdosing a little bit. Jenny, who's worked many, many years in obstetrics, reminds us about the importance of iron throughout pregnancy. And yeah, Claire, so you had some provocative ideas about the ferritin cutoffs, which I thought was actually good, because the reality is that we cannot easily extrapolate iron deficiency diagnostic criteria to all populations. I think that is the bottom line. There's this article that was published earlier this year by Truong in the Lancet Hematology, which I think is very useful. Basically, it was a proper systematic review that looked in depth about where do we get our ferritin cutoffs from. And what they basically said, and they detail this, the quality of the studies that created these cutoffs extremely poor. that as a general rule, people did not follow the guidelines for creating cutoffs. 3, they, in the vast majority of instances, did not screen just by history for patients at high risk, people with heavy menstrual bleeding, people who've had recent pregnancies, people who are blood donors. So they included people with, or likely included many patients with, or people with iron deficiency, and thereby ended up with these very, very low cutoffs. Or they just simply looked at what level did people actually become anemic. And you really showed us very nicely that the non-anemic iron deficiency is very important. I'm going to hand over. I see, is it Amour Lang has got her hand up, or his hand up? Amour Lang, please go ahead. You can just unmute yourself and ask your question.
Yeah. Hi there, guys. Thank you so much for the presentation. I actually, mine is quite a simple one. Coming from the sports and emergency medicine background, I just wanted to find out, when we denote the term the female triad, is this term readily interchangeable with what we would refer to as the REDS term, so this relative energy deficiency syndrome, on a broader classification? And in identifying, as you've said, we usually use it in female athletes who are amenorrheic, who we know, especially in runners, where it's well studied. Are these two terms interchangeable in that if a patient comes with these symptoms, or we define it as REDS, but in actual fact, is the iron deficiency a subspec of that RED syndrome? And that's how we then branch into the investigative pattern. Because I hear when we say that we should quarterly be screening these athletes quarterly, given some of the sports franchises' budgets, it sometimes becomes very difficult for us to catch these athletes at that stage. And so I just wanted to find out, is this the same thing as REDS? And do we investigate it in the same way? Or are we just sort of using the same terms to define the same things? Thank you.
And I'm certainly not, but yes, I think that these are, and really I bow down to your knowledge of the subject, but I think REDS and LEA and the female triad are pretty much, in my understanding, are parts of the same thing. But what the point I was trying to make is that iron deficiency just would make this even worse, and that these are the exact people who are at the highest risk for developing iron deficiency. So, and I think that that's why in the article that I cited by Peeling, is that patients who have got REDS should actually be screened quarterly for iron deficiency due to their particularly high risk.
Great, thank you for that interesting question and the answer, Claire, as well. Belinda Kirk says, thank you for an excellent, thought-provoking and practical talk. And Johanna Bolt asks, where does iron infusion fit in the treatment of iron deficiency in this particular patient group?
I don't know, Vernon, if you've got thoughts on that. So for me, I'm, like I said right at the end, I'm very guideline focused. So I think that you need to make sure that this patient has actually, you know, whether if there's a specific reason why this patient has got an indication to give iron, parenteral iron upfront, then you should follow it and give that patient. For instance, if it's a pregnant woman and she's beyond the first trimester, by all means, I think it's silly to fiddle around and give oral iron. But I would give them 3 months of oral iron. And if there is not a response, you know, without a good reason to give parenteral iron upfront, I don't think that it would be right to go straight for parenteral iron, in my opinion.
Yeah, I would support that. I think the biggest decision maker here remains cost and reimbursement, although I have to say the insurers are getting a lot better. There's been a lot of good updates very recently. As Claire was giving a talk, somebody WhatsApped me to say the iron infusion that they expected not to be approved was approved, and it's a message we're now hearing more and more. I think people are catching on to the importance of this, and but I agree. Usually we would do 3 months of oral treatment if no response, or if they don't tolerate it, then go to IV. Yvette Candy, interesting talk. Thank you. Marius could see it. Drinking iron at night seems like a good idea, especially if you had your evening meal a few hours ago. Don't know, Claire, if you want to comment on that, or...
I don't have something extra to say to that. No.
Yeah, so I think just monitor, because it's interesting. The benefit of taking it at night, of course, is that you can sleep through some of the side effects, perhaps. The other side of the argument is that hepcidin is lowest in the morning and higher at night. Some people think morning might be better for that reason. Of course, with your evening meal, that would be fine with all the supplements we now have that can be taken with food. Ferrous sulfate might be less good for an evening dose than with food. Great, thanks, Marius.
Vernon,
Ruth, yes, go.
but perhaps, with the smaller molecules and the molecules that are absorbed independent of hepcidin, I think that, and I mean, even the Anova product can be taken with meals even, so I think that a lot of these statements were made based on ferrous sulfates.
Sure,
but,
sure.
And perhaps one can be more lenient and, with the smaller iron molecules as
Sure, and thanks for highlighting that. I think it's important if you're taking a medication that bypasses hepcidin through another pathway, then it doesn't matter. Ruth Gopi, excellent presentation, Claire. Light bulb moment for me with regards to vitamin D. She says that she had a young adult female with irregular menses, confirmed iron deficiency and vitamin D deficiency, and history of anxiety. Thank you. So, yeah, I thought that was good. Vitamin D deficiency is surprisingly common.
Yes.
In Cape Town, certainly. I don't know if the parts of the country where, or sub-Saharan Africa, where our listeners come from, but I think we are so scared of skin cancer. If we don't cover ourselves up, we cover ourselves in a sun protective cream. And vitamin D deficiency, I mean, I test it very commonly, and I would say 1 to 2 out of 3 vitamin D deficient. So thanks, Ruth. Johanna says thank you. Recorded version of the session. Yes, Pradeep, the iEcho platform on YouTube will have the recording. And then Belinda says she would have liked to scan the QR code. And yeah, she struggled with the phone. So Claire, I don't know if you want to share it again.
Let me quickly do that.
Okay. And then Johanna says, I think we forget that we need the vitamin D to be activated by the sun, but a baseline of vitamin D has to be in the body. I may be wrong. Okay, I don't know if you've got any comment on that. Just perhaps while, yeah, thank you for that reminder, Johanna. That is important. About cutoffs, Claire, you asked about our recent studies. David Richardson, who did his master's on iron deficiency in HIV, inflammation, TB, and malignancy, looking at actual bone marrows. And the cutoff and this cutoff is important because it's not for functional iron deficiency. This was a cutoff that predicted absolute iron deficiency in the marrow. And it turned out that in that particular population, which I wouldn't extrapolate to just anybody, we will have to repeat this in other groups, the serum ferritin less than 80 was a superb predictor of iron deficiency. And so I don't think one can criticize your 50. There's been previous studies that used higher cutoffs, close to 50. And if you look at the physiological data, we see that the compensatory mechanisms of the body, there's been 2 studies in the last year or 2 that showed the compensatory mechanisms kick in when the serum ferritin goes below 50, like soluble transferrin receptors going up, etc., etc. So I think that's not a bad cutoff. Now, that said, at the moment, we're working with the laboratories to change the cutoff they use to 30, because that's the one that's got the greatest sensitivity and specificity so far. and we're in the process of submitting a letter which has already been drafted to the chemical pathology expert committee, and we hope that the cutoffs will soon be changed. Great. I think we've, with all the excitement, we've now even gone 10 minutes over time. So I must thank, and the people are still in the room, you know, that's for me the thing that tells me this was good. So thank you for staying, everyone. This is our last PBM session of this year, and I want to say thank you to everybody. When I look at the list of names, I see that we've got a lot of people that are regular supporters of our PBM Echo meetings. So thank you for the support during the year. Special thanks to our the people that lead us, and I'm thinking here of Prof. Chris Kasianides, the people that organize these weekly meetings. Thank you so much, Karen and Fenton and Cheryl, for all the work you do. Thank you to everyone who's been speakers on this talk. It's been so great to have such wonderful talks and speakers. And we look forward to a good 2025. We'll think up new interesting topics. And I don't know, Chris, if you want to say in closing, but before I go, maybe just say next week, it's going to be lower GI endoscopy for the gastroenterologists amongst us that have got an interest in that. It's got a major overlap with iron deficiency diagnostics, of course. But from my side, a huge thank you to everyone and a wonderful festive season, end of year, until we see again in 2025. And thank you, Claire, in particular, for the most wonderful talk. Bye-bye.
Thank you.
Thanks, Claire. Thanks, Vernon. Cheers.
Bye, Chris. Bye.
Bye. Thanks. Excellent. Thank you so much. See you
Bye.
soon, Vernon.
Bye-bye. Thanks, Chris.